My sister was diagnosed with liver failure. We didn't realise how poorly she was at the time. Having a discussion about an agreed plan with the healthcare professionals and the family unit is a huge benefit. We discussed the preferred places of care for her. We asked her where she wanted to die, and she gave us her answers, and that was all put in place by the hospital discharge team. In the end, my sister died where she wanted to be. She wanted to be at home. She was in her surroundings that she was happy in, and that was the best place for her. And because of that, she went in her sleep, and as a family as well, we were happy that we were surrounded with her. We were there with her, and she just went peacefully in the end. Yeah.
When explaining what EPaCCS is to a patient, I would tell them that the discussion that we've just had about their preferred priorities of care around the last stages of their life needs to be documented. And essentially all EPaCCS is a document that will be existing on GP records, but that will be able to be widely shared with any health and social care practitioner that would be coming into contact with them.
I'm Sally Turner and I'm 66 years old. I've recently been told that my lung cancer has spread. I live on my own and I'm really scared about the future. I'm going into hospital next week for more chemotherapy. Last time it made me feel so ill, I'm not sure I want to do this again. I'm going to see Dr. Baylor because I know he's really going to listen to me.
I'd create an EPaCCS record for anybody who I think is approaching the end of their life. And these are the people who you find it fairly easy to have the conversation with because it's starting to come quite naturally.
EPaCCS can be very useful for situations where you have the frail elderly.
People who have really bad heart disease or such bad chest that they can't move around their own house.
Patients with long-term medical conditions, COPD being one of them.
And sometimes people are going to have things like renal dialysis.
I got the letter from a consultant last night, and the consultant said Sally is not sure whether to go ahead with the future treatment.
Last time it just made me so ill. It was worse than having the cancer. Do you know, this time I'm really not sure.
The EPaCCS system is a core part of how modern healthcare is going to be delivered going into the future, because it's all about putting the patient at the centre, coordinating their care and getting different organisations to work together around the patient to ensure that the care that they need is delivered in a timely fashion, in the way the patient wants it to be delivered and in the place that they want it to be delivered.
I don't really think I want to spend all that much time in the hospital.
What we have with our new system called EPaCCS, we can record your wishes and preferences, like for now and for the future.
It's really important to have that conversation and perhaps try and bring in carers and family as well, because the patient might want a certain thing, but that might not be something that the family want. But when they realise that that is the patient's wishes, it's much easier to document and record this and to make sure that it actually happens.
The real challenge about EPaCCS is it has to have leadership and it has to have real buy-in from the clinicians, because it is really difficult. It's about trying to encourage people, A, to have very complex and difficult conversations with patients, being willing to do that, but also then to record that effectively and in a summarised way and get that onto a computer system, and then trust that other people are going to read it and understand it and recognise it for what it is. And that takes a lot of encouragement and leadership.
My son was diagnosed with cancer in 2004, and just over 5 years later he died. The day before he died, a nurse said to him, "Neil, what do you want?" And he said, "I just want to be at home." And she arranged everything during the next 16 hours. She arranged all the services he needed. So the following day, he went back home to his flat. And he settled himself in there with all the things that mattered to him, vinyls, books, they really mattered to him, that. And during those last 16 hours, he met and talked to all his friends, and finally he had his family around him. And he died at 8 o'clock the following evening. He was at peace. I was there with him. It was a good death. And it was a good death because he was able to express what he wanted, and professionals were able to put everything together to make it happen.
There's two reasons you'd use an EPaCCS template. Firstly, as a clinician, you're using it because it's giving you a structure to record this information. It means you're following a kind of framework, which is the same as everyone else then, so you're making sure that you're not forgetting anything, you're recording it in a proper way. From a technical point of view, it's really important that information is recorded in a structured way. So using a template might be attaching particular read codes in the background. And this is really important because it actually enables the technical side of EPaCCS to happen. It allows the information to actually be shared.
It is very complex to try and coordinate different electronic patient record systems, and as a clinician I'm going to be very honest and say there is so much jargon and so many bits of information that I don't understand, and it can be very daunting and it's very easy to be put off by that. But if you get beyond that complexity of what's going on, that complexity, while still there, can be overcome, but it does take commitment, time and leadership.
It wasn't until Neil died that we realised how many different organisations and resources had come together to make it possible for him to have those few hours in the right place.
The sort of people that will access an EPaCCS record are any healthcare professional that's involved in your care. So that's doctors, nurses, pharmacists, physiotherapists, and a wide range of people. But it's always going to be with your consent and with your knowledge.
The interesting thing about consent with EPaCCS is that patients actually think a lot of the time that it's happening already. More often than not, they'll be surprised that you're asking if information can be shared because they'll think that you're already sharing information with the emergency services, with the hospital. And just make sure that you are asking their consent, that they do understand who you're sharing the information with.
Okay, Sally, I'm just going to take your drip down, and then what I'll do is we can talk about your next appointment and give you some important information and contact numbers.
Well, that's fine, but I'm not absolutely sure I want another appointment.
Sounds like you've got some concerns.
Yes, I've been sitting here thinking, is this what I really want? I'm wondering, is there a doctor here that I could speak to, please?
Dr. Mackay is on the unit. I could go and get him for you.
Fine.
One of the areas that we would always have discussions around is about the goals of treatment, the goals of care, and that does involve discussions around their wishes for the future.
I've been talking to Kirsty and she said that you're concerned about your chemotherapy, is that right?
Yes, it is right. I've been here all day and I've been sitting here and thinking, and I've come to realise that I don't think I want any more chemotherapy. But now I don't know what to do and I'm getting really anxious.
Okay. I've been reading your records and I understand you've been having some discussions with your GP about this. How about if we discuss how you're feeling now, and then we can share the decisions that we come to through your EPaCCS record?
Well, that would be very helpful, thank you.
With cancer in particular, the treatments may change quite quickly. The disease itself may change. And because of the rapid pace of change, it's really important that we capture that information in a timely way, in a timely manner.
Any new information that is shared with the clinicians does need to be updated on the EPaCCS template so that anybody else that comes into contact with that patient knows that patient's last and latest wishes.
A lot of our patients want to die at home, but when the reality hits and when they are actually dying, quite often they want to change their mind because they feel frightened or because families feel they can't cope. And we can change that onto the system so that everybody knows that, and straight away it's updated, and as soon as we've added that, then the change is there for everybody to see.
In my service, so in hospice at home in particular, that transition from days to nights and nights to days is much smoother. So the district nursing service, they're the main carers during the day. They're able to see what hospice at home have done. They're able to see what care has been delivered overnight. And again, for hospice at home coming on later at night, they can see what's happened with that patient during the day.
It just makes life so much easier. It makes documenting things easier, being able to find things and to care for your patient. I think it just improves everything about your working day, really.
Hello, it's Dr. Clark.
EPaCCS is particularly important during the out-of-hours period because these patients are all new to ourselves. So we're not their GP, so we're covering a very large geographical area with lots of patients, so we'll have numerous calls from patients that we don't know at all.
Oh, hello Sally. I hear that you've called us because you've been feeling short of breath.
That's right. I know I've got lung cancer, but it's this shortness of breath that's worrying me.
I can see on my computer that you've got an EPaCCS record. Would it be okay if I have a look at this so that I can get a bit more information about you and your condition?
Yeah, that's fine.
It's always very difficult as a clinician to keep asking to ask somebody who's rung, who's clearly very poorly. For instance, they may ring, say, I really can't breathe, I'm fighting for my breath, and you have to say, to ask somebody, do you have a diagnosis of COPD? Are you end of life? Is really inappropriate. So to already have that information is essential.
I can see from your records that you've been having some very difficult conversations recently. You're not sounding too short of breath on the phone at the moment. Do you find that the breathlessness comes and goes a bit?
Yes, it does.
Patients expect us to know about their health, and often without a care plan you wouldn't know, because we're dealing, especially in the out of hours period, patients who we don't know.
So I noticed from the shared record that you've got some medication now to help with your breathing. How are you doing with that?
Well, it has helped. It certainly has helped, but I would like to have more control myself because I'm on my own and I just want to stop this panicking.
Yeah. So how would you feel about attending the hospice and completing the breathlessness course, which they will teach you strategies on how to put you back in control of your breathing?
Oh, that sounds a great idea, thank you.
That's great. So with your permission, I will refer you to the hospice, and if, with your permission, I'll update your shared record so everyone knows the conversations that we've had.
A huge part of all of this is about trying to get patients and those who are important to them to lead their care and to do what they can do for themselves, and actually for the professionals to be the safety nets that pick up the pieces when things perhaps go a little bit awry.
Okay, we're going to talk about our first patient. It's Sally. She's a 66-year-old lady. I can see from the EPaCCS summary that she was diagnosed with lung cancer 6 months ago. She now has metastatic disease. She's known to the district nurses and the community Macmillans.
The idea of a GSF meeting is to bring as many of the professionals and carers together. Usually at a GP practice is where they take place, and we talk about patients who may be in the last 12 months of their life.
I think we'll be all surprised if she continues with a full treatment, really.
It's great to get the district nurses, the GP, social workers, nursing home staff, Macmillan nurses, and all those people involved in that patient's care. While we're actually discussing at the GSF meetings, the EPaCCS record can actually be updated while we're at the meeting. So either the GP or one of the GSF coordinators in the practice will probably be updating the EPaCCS record as we're discussing the patient.
ACP 802 receiver. Roger, can you just confirm the address? Shortness of breath and she's got a care plan in place. Okay. Roger, details received. One mobile now, move on.
If a patient deteriorates suddenly and the ambulance service is called, the service can then view the latest information and preferences and wishes for that patient and then respond appropriately.
Turning up at the scene of any incident can be a challenge.
It's open.
Obviously, when you're faced with patients with complex needs and clear wishes, you know, it's a system such as EPaCCS that provides information for clinicians and patients and relatives. It's a no-brainer.
If it's all right, we'll just have a quick look at your care plan and then I'll get on with some routine observations, if that's all right. It's fine. God.
At 3 in the morning particularly, there's not always pathways available, there's not always advice available, there's not always senior clinicians available, and the ambulance service have a habit of becoming the default safety net for these people. So if we arrive at these incidents with insufficient information, the risk is we make inappropriate decisions that are against the patient's needs or wishes.
They are really quite upsetting, emotional jobs and any kind of end of life. So at least you want to be making sure that ethically, morally to yourself that you're doing the right thing by the patient, absolutely.
Just on scene with a lady who called Sally Turner, who I believe you know quite well.
Yes, I know this lady. I think the last time we discussed her in the Gold Standards Framework meeting, she didn't really want to go into hospital. I will just check her EPaCCS.
Yeah, she's adamant she doesn't want to go to hospital at all, and from the assessments we've done, we don't feel the hospital's the best place for her at this time.
Yeah, I mean, I can call out to see her within the next couple of hours. I can see that she's got some anticipatory medications in the home.
Yeah, there is some here. The observations we've done as well, they're all within normal parameters, which fits in with the care plan. So that'd be absolutely brilliant if you could be in the next couple of hours. I'm sure she'd be quite happy with that.
The benefit to EPaCCS, it will give us that clarity that we need at the scene of a complex situation, sometimes an emergency situation. And clarity is something that you need quickly because you need to act appropriately.
It always feels very uncomfortable as a senior doctor in an emergency department going and speaking to patients or to relatives who are on an end-of-life care pathway and not actually having the information about previous conversations at your fingertips. Patients sometimes do have that conversation about what they want to happen in the event of coming to hospital and being very unwell, and that conversation can happen when their health and their communication is easier and better, and when they come to the emergency department, quite often they're so unwell that you cannot have that conversation, and that's a very difficult situation to be in. And again, having the information on an EPaCCS system so that we can see what has the conversation been had, what the patient's wishes were, what the family's wishes were, makes it an awful lot easier.
Hi Sally, I just wanted to catch up with you today before your next session to see how things are going for you and how are you feeling?
Well, I'm really enjoying being here in the hospice. It's not a bit like I imagined it would be. In fact, I really feel quite safe here. And it's made me think, if things get pretty tough at home, what are my chances of being able to book in here if things get difficult towards, at the end?
That's fine. I have noted on your shared record though that you have expressed that you'd like to be at home towards the end of your life. Have you changed your mind about that now?
Well, that would be my preference really, to be at home, but if it gets really difficult, I'd really like to know that I'd be able to book something in here. Could I put my name down for it?
Absolutely, we can look at doing that. What I can do today is access your shared record again and update that so that everybody looking after you is aware that you'd be interested in coming to the hospice if you can't manage at home at the end of your life.
Oh, thank you so much. I'm so relieved to know it's now going to be written down for me.
Okay.
Thank you.
The EPaCCS system has so much potential, particularly if we can get it rolled out across the country.
There's abundance of evidence and stories, and both anecdotal, to demonstrate that care plans work.
You're only recording information in one place, you're not having to go through different systems. You can record it in one place and be sure that it's going to everyone else that information needs to go to deliver the benefits to the patient. So it's about making your life easier as well.
For patients, it saves them time as well and energy, because quite often our patients are very fatigued, and if you've already got that information down, we don't have to keep asking them and keep asking them. Patients quite often get fed up of being asked the same question by different health care professionals over and over again.
From a hospice perspective, we want patients to be able to have their lasting wish, which would be either to die at home or to die in hospital or their preferred place of care. So I think EPaCCS has enabled that that multidisciplinary approach to supporting patients to have their wishes and preferences met.
The huge advantage of having a specific system that's dealing with end-of-life care is that you have immediate access to the relevant information quickly, and that's the enormous advantage, and I think that's the selling point.
If you need to know more about an EPaCCS and how you can use one, you need to contact somebody from your CCG who is involved in end-of-life care, or perhaps you might have an EPaCCS task group that you can contact as well.
To find out more about EPaCCS within the hospital setting, I would go and speak to the palliative care consultants or any of the palliative care team.
You can also contact your out-of-hours provider who will be providing and supporting EPaCCS across your local area.
The local hospices has a wealth of information about this sort of subject, so that would be a good start.
Speaking from a personal point of view to anybody who's not already got this in place, it's a huge benefit to any family. It's peace of mind to a family when they're most vulnerable, they're emotional, they've got a family member who's poorly. You've got the confidence that everybody dealing with that person's care has got all the facts at their fingertips.
Looking back on it, there were so many bad times during the 5 years from diagnosis to death. There were so many times when we despaired and we thought things couldn't possibly go right. Now, with a bit of hindsight, I suppose, I have some very good memories. I have some good memories of Neil being in his bedroom with all these books around him. I have good memories of Neil saying, can I have a biography of Manic Street Preachers, one of his favourite groups. I have good memories of him being in his room with the Liverpool banner because he was a football supporter. All those things happened because people listened to what he wanted.